It's time for Kadlec on Call on 610 KONA. It's your opportunity to call in and get your health questions answered. Call 547-1610. That's 547-1610. Now, here's Jim Hall.
And a very pleasant good evening, everyone. Welcome to another edition of Kadlec on Call. Each Wednesday at this evening, we come your way and talk about a particular health or medical topic from 6 to 7 p.m. And tonight, I think we may be just about the healthiest place in the Tri-Cities because I count at least 3 physicians here in the room. So if anything goes wrong, we're in great hands because tonight we're talking about a brand new medical residency program here in the Tri-Cities. We've addressed it on our this program before, and it's really exciting news for our community as it relates to healthcare and how it's provided throughout this region, because we are training the physicians of tomorrow here now at Kadlec Regional Medical Center. It's really exciting because Kadlec has joined the University of Washington's Family Medicine Residency Network, and this past July, 6 residents, so they have completed their medical school training, are now doing a 3-year residency, and when they're finished, they will be out seeing patients solely on their own. They're actually seeing patients now as part of their training. But we wanted to bring them in. They've been in practice since July, and we wanted to bring in not only some of the physicians who are part of that program, but the people who helped get the program started and who are training and teaching these physicians here in our community. So it's a fun night for us because it's been a lot of fun to help get this program started in the Tri-Cities and educate the folks, because I think probably the greatest point to make here is that, and we can get to that with our guests tonight, is there's a shortage of physicians across the country. And so now Kadlec is doing its part to help meet that need, especially in some of the rural parts of the population. So that being said, we have with us tonight Amy Carrasco, who's the Director of Graduate Medical Education at Kadlec, and Dr. Eric Isaacson, who is the Program Director of the residency program at Kadlec. So he's overseeing the training of our 6 residents. And we'll introduce later in the show Tyler Clark and Tayab Tahir. They are medical residents, 2 of the 6. And traffic being cooperative, we'll have a 3rd. We're expecting Janesh Shah, also one of the residents here as well in the Tri-Cities. But let's start with Amy and Dr. Isaacson. But Amy, first, I know you've spent a ton of your time the last several years developing this program, but maybe for the audience that isn't familiar with what a residency program is, explain just what it is and how you become a physician, I guess, once the residency is completed.
Great. Thanks, Jim. Students that want to become physicians go through initially and complete their undergraduate degree, and then they get selected to go to medical school. And then after they have then graduated from medical school, they then decide what type of physician they want to be. It's during their medical school experience that they are exposed to all different types of specialties, whether they want to be a surgeon, whether they want to be an obstetrician, family medicine. And so then they apply to residency based on what they want to be. Kadlec made the commitment to have primary care physicians so that we can take care of our population in southeastern Washington. And so once then you're selected and matched to go into residency, then the family medicine program is 3 years in length. And so each year we'll have 6 new residents arriving in July, and this class and this group of physicians here will graduate in 2018.
Dr. Eric Isaacson is the program's medical director, and Dr. Isaacson, for those who may not know, is a longtime family physician here in the Tri-Cities. He's a graduate of the University of Washington Medical School, so I know it has to be really near and dear to your heart to be a part of this program as it gets rolling.
Yes, it really is. It's been really satisfying. In fact, this project has actually put me back in contact with some of my medical school classmates who are also involved in the Family Medicine Residency Network. And so it's been a little bit like a class reunion to be working with these people to get this program developing. Now they're close to changing their careers and getting onto retirement, and I'm just beginning a new project, which I find really exciting, but also kind of ironic about the whole thing. But it's more that I'm really satisfied to be part of this.
If you could, and maybe start with you, Dr. Isaacson, and Amy, fill in as well. Give us an idea. We've touched on that there is a physician shortage across the country. What does that mean? Is it just that more and more physicians are getting ready to retire, and obviously with the largest segment of the population being older and needing more health care, that it's just a math equation, the supply and the demand?
Yes, it really is. I think it's estimated that over half the family physicians, particularly in this area, are over 50 and getting to the ends of their career. And so there's going to be a sort of a mass exodus of us baby boomer physicians to retirement, and there is not yet in the pipeline primary care physicians to take our place. So beginning this program in primary care here is really key to meeting the needs of southeastern Washington.
We have limited time, but I want you and Amy both to address at this point, what does it take to get a program started? I know there's a great deal of work to, there's things such as just getting accredited and all those kinds of things, but I don't know that, at least I didn't know, and I'm guessing the public doesn't know all of the work that has to go in from a curriculum and all of those kinds of things. Maybe start with you, Amy, the work that's gone into just getting this program where it is today.
Well, it's taken a great deal of time. Kadlec's been considering starting a residency for a number of years, and it was something I was kind of doing on the background for about 7 or 8 years, researching, finding out how we could do this financially feasible and have a quality program. Once we made the decision to go, it's normally a 2-year process to become accredited through the Accreditation Council for Graduate Medical Education. And we were in a fast-track position and got it done in about 9 months, 10 months maybe. And
it was very fast.
It was very fast.
But we had a lot of work in advance of it with our partners in the network and all that too. So
yeah, we couldn't have done it without the help of the network, but developing curriculum, hiring the program director, associate program director, and then in addition, we needed a facility, and so we had to remodel a building.
Well, and also you touched on the faculty. I mean, obviously you're still a practicing physician as well, but you also had to have other physicians in our community join the instruction group to provide the education. Correct?
Yeah, our program is certified by what's called the ACGME, or the Accreditation Council for Graduate Medical Education, and that is the allopathic MD pathway to becoming a board-certified physician. And so we had to jump through all of those hoops. And first of all, Kadlec had to be approved as a sponsoring institution. That is, they had to provide information that assured the ACGME that there was enough volume of patient care and sophistication to satisfy the training needs of family medicine doctors. And then once the institution was accredited, then we had to go back and then apply and be accredited for the family practice residency. And so that institutional accreditation, again, because of the work that Amy had done earlier with the network, we got the institutional accreditation done in just a few months. And then instead of having almost 15 or 18 months to get the program accredited, we actually got compressed into a 9-month process, where it was in part because of the merging and unification of the American Osteopathic Association and the Accreditation Council for Graduate Medical Education, but that's created a lot of movement in terms of accrediting activity, and our time frame really got compressed, but thankfully because of the 7-8 years worth of work and our partnering, we were able to get this done in a much shorter time frame. We're really, really happy to have that accomplished.
And I know starting these programs are not inexpensive, and certainly that's one of the challenges, as I understand it, that they are very expensive to start, and so that in itself helps contribute to the shortage we're talking about, because all of the training has to be synced up, and at different levels of where you are in the training, it doesn't always match up. So when you finish one to go to the other, that doesn't work. So I know Amy was saying there's a huge every year for the people wanting to get into residency. There just aren't enough slots. So to be able to just have 6, it may not seem like a lot, but that's 6 more that the prospective physicians have, right? So talk a little bit about Amy, that demand.
The demand is that there are so many people graduating from medical schools that there aren't enough residency slots nationwide within the U.S. And that number has grown each year. I think when we first started looking at this and really paying attention to it, there were like 500 graduates who couldn't get into a residency nationwide that were U.S. trained. And then the next year it was 700, then 900. This last year was 1,093 graduates, U.S. trained graduates, could not get into a residency.
Amazing.
Right. And so that number is just growing exponentially. And last year was our first year when we were recruiting and interviewing this great group that we have. But we had 530 people apply to a brand new program. We didn't even have a building at that point.
And now you're out looking for the next batch of 6, correct?
Correct. We're a week into looking at applications, and we already have over 500 applications. So we think we'll be over 1,000 applicants.
So a lot of reviewing happening.
A lot of reviewing going on, yes.
Well, the 6 that are here, I've heard great things about, and it sounds like this is a real high-demand place, and being the first place, being that first class has got to be neat. And throughout the course of the hour, we'll be visiting with 3 of the physicians who are in training here at Kadlec. We have to take our first break of the evening. We're talking how to become a family practice physician and all of the work that goes into it from the student's perspective, the physician's perspective, and the people who are making the program happen's perspective. You're listening to Kadlec on Call. We will be back with more in just a minute.
You're listening to Kadlec on Call on 610 KONA. This program is not a substitute for direct consultation with your own healthcare provider. Always consult your healthcare provider for your specific condition, especially if you have or suspect you may have a medical problem. Now back to Kadlec on Call. Here again, Jim Hall.
And continuing our discussion about Kadlec's Family Medicine Residency Network. And I promised that we'd have 4 physicians in the room, and we do. So any healthcare conditions, we're going to be in great hands tonight. But we have 3 of the members of Kadlec's first residency class, along with Dr. Eric Isaacson, who is the program director for the Kadlec program and an alumnus of the University of Washington's Medical School. And so I want to start with Dr. Tyler Clark, because we're going to go nearest to farthest, because Tyler actually is from Lewiston, Idaho, I understand, and he is now in the Tri-Cities practicing and becoming through his residency. And Tyler, I guess first of all, just share a little bit for our listeners about your background and how it was you decided to become a physician.
So yeah, I grew up in Lewiston, and I did my undergrad at the University of Idaho, and I basically just wanted to get into medicine to help people.
Really? Was it the family practice arena? I've heard, nurses and doctors, they kind of start out in a wide array and then they zero in on something. Was it always the family practice side that you wanted to do?
Well, going through rotations in medical school, basically I just wanted to get into the most collaborative field of medicine, and this seems to best fit.
How's it worked so far since you've been here?
It's great. I've really enjoyed my time here so far.
And that's Tyler Clark, and we're going to move down the table. Janesh Shaw, Dr. Janesh Shaw, just found his way to KONA studios, and we're happy to have him here. Tell us a little bit about your background and what your impressions are of going through this residency program 2 months in, I think.
Sure, Jim. Thank you for having me here. So I'm originally from Bombay, India. I was born there. I came to the United States when I was 16, moved to Maryland. I've lived there ever since, did my undergraduate at University of Maryland. And after that, I did some research at Walter Reed, worked at Johns Hopkins for a year, worked with a cardiologist in Florida. So went around the eastern part of the United States for all of my clinical rotations, and did my medical school in the Caribbean, in St. Kitts, and eventually ended up here for residency. And I guess the way to residency and why family medicine, I would say that just having started my undergraduate in biology and molecular genetics is what I was doing. I used to do a lot of research-based science, and I wanted to kind of integrate that into the medicine aspect of clinical science as well. And family medicine for me was kind of the best way to integrate all of that together in patient care. And I truly believe, I said this even when I was applying, that family medicine for me is a way to educate the patient, not only in taking care of themselves, but to be proactive about taking care of themselves. So I'm trying to prevent diseases rather than cure diseases, and that's why I'm here at Kadlec.
Well, that's awesome. And now we have Dr. Tayeb Tahir, and share with our listeners a little bit about your backstory and how you arrived in the beautiful Tri-Cities.
Sure. So I was originally born in Pakistan, but I grew up all the way across the country in Georgia. Graduated from the University of Georgia. Go Dogs.
So Bulldogs,
Oh, yeah.
we have Gamecocks, and we have we have two Vandals, I know.
Oh, yeah.
Amy's a Vandal.
Yeah. Sorry about the Gamecock reference, but yeah, and then so after graduating...
Terrapins, Maryland. I'm sorry, you're the Terrapin.
Yeah.
I had the wrong mascot. That's on me. I know you're a Bulldog, though.
Yeah, oh yeah. Hard.
All right, go ahead. Sorry.
So after graduating from the University of Georgia, I went to the Caribbean for medical school. Went to the American University of the Caribbean in St. Martin. And then I did a lot of my rotations, mostly in the Northeast, New York, Baltimore. Then, so basically I traveled a lot, so I was never really connected to any one part of the country. So when it came down to residency and choosing where to do my residency, I wasn't particularly worried about what portion of the country, and I was more focused on the program and what it had to offer. Mm-hmm. And over here at Kadlec, well, first of all, in the Tri-Cities, everyone's been amazing, very welcoming, very warm, very friendly, and that kind of drew me in. And then on top of that, having to meet Dr. Isaacson and Amy and some of the other staff, they were amazing during the interview process. And just the family medicine residency itself, we're the only residency at Kadlec, so that allows us to have a wider and broader range of pathologies and patients that we get to see. So considering all those factors, I decided to choose this place, and so far so good.
I have to ask both you and Janesh the question of, okay, when you heard about the Tri-Cities, did you think mountains and rain and that kind of stuff when you thought of Washington State?
Well,
honest.
The first time when I heard about Washington and the Tri-Cities program, I did think about mountains and things, because I've only heard about Seattle so far in Washington.
Sure.
And Yakima was the other place I had heard about, but then I had never been here, but I was really excited to actually finally visit the area, and I actually stayed for 4 days during my interview, and really enjoyed the geography and what it had to offer, and I'm really happy I'm here today.
Tyler, a question for you. Okay, you guys started seeing patients in July. Maybe just share a little bit about what your day is like. Give us an example of what your day is like.
So every day since starting in July has been a little bit different. We have 2 half days a week where we're in the clinic for 4 hours and we see a few patients, and then I've been rotating through hospital medicine, inpatient pediatrics, and OBGYN. So it's been a good mix of a lot of different stuff. So
you're actually seeing patients, and then you're also doing classroom work, and then you're also in the hospital. So you get the full meal deal.
We have full days.
And then, Janesh, same with you. Are you all doing different parts of it and then doing your classroom work together, or how does that work?
Well, it's pretty much similar. The schedules are a little different for all the residents. So I started with hospitalist medicine, and then I did pediatrics outpatient. So we actually get to train with clinics outside of just the hospital. And also, like Tyler said, half-day clinics. So far, the patients that I've had in half-day clinics have also been really excited with what we have going on, because they not only get to see me as their physician, but they also get to see either Dr. Isaacson or one of the other faculty members. So they're getting 2 physicians for the price of 1, and which is really awesome in terms of their care. And we get to come to a radio show and do an interview, too. So,
we got the most popular residents in the country, I think. But Dr. Tahir, and get the mic over to Dr. Isaacson for a quick second, because you bring up a good... Well, actually, I need this mic for Dr. Tahir. We're playing... We have 2, 4, 6 people in the studio, and Kevin, but we have a limited number of mics. But I wanted to have Dr. Isaacson weigh in after we address Dr. Tahir the same questions of, so when you're seeing patients on a daily basis, one of the physicians, either him or Dr. Carlson or one of the other faculty members, is with you, so it's like a consultative visit for the patient?
Correct. So the patient really gets advantage of having 2 physicians examine them at once, like Janesh kind of stated. So I go in there after the nurse is done getting all the vitals and the patient information and why they're here. Then I go examine the patient, get their history, do their exam, and I give them my perspective on what's going on with them and what the best treatment options are. Then I consult with Dr. Isaacson or whoever the preceptor may be that day, and we go over the plan. We talk about it together. We weigh our options, and we talk about which treatment option is better compared to some of the other alternatives. And then we go present that information to the patient. The preceptor also examines the patient, and then we discuss with what the patient wants and go about the plan that way.
How is that like, Dr. Isaacson? You're used to obviously having been in private practice, just, when you go in, it's you and the patient, but I bet that's really an interesting process.
Yeah, I think I have to confess that that's probably the best part of this job is to precept the resident clinic. And I've really been fortunate and blessed by a number of the patients that I've cared for over the last 33 years in town here that have chosen to follow me to the residency clinic. And so it is a little bit of a reunion with patients that I've cared for, and it's a little bit of me learning to trust other people to take care of these folks that have been in my care for 33 years. So, and most importantly, I like to make sure that patients understand that patient safety and appropriateness of care is the number one goal of this residency program. And so, but it's also helping physician learners learn their skill set well. So we let the residents go in initially to begin that collection of history and physical, form a plan, and then come out and talk with an experienced board-certified physician about what they found, what their plan is, and how they want to communicate that to the patient. And then I'll go back into the room with them, or the other faculty will as well. And if there's some physical exam items that we need to confirm or look over a second time, we'll do that. And then it's my turn to kind of step back and assure the patient that we've discussed this plan, and then have the resident physician explain the plan to the patient. So it's all that developing that skill set of communication, of interviewing, and being organized, and to communicate in a patient level what's understood for the day and what's the plan to take care of them for the future.
And was it that way when you were training? Is it evolved over time? Is it a lot different today? Is there more communication now with the patient than there was maybe when you trained?
It has changed a lot. When I trained, it was what's referred to now as immersion training. That is, you were thrown into the pot and boiled for 3 years and popped out the end. And they were pretty sure that you learned your skill set. There was a board certification exam too, but now there's a 23-page document that describes the residency program requirements, and there are 6 competencies, there are 23 sub-competencies, and 230 milestones that we're to be evaluating our physician learners on the basis of as they develop an enlarging skill set to become independent physicians who can practice without supervision.
And these are, and that's, I guess, the thing, too, that maybe people are aware. These are physicians. They're just now getting their residency, so they've finished medical school, so they're docs.
Yeah, they're physicians, but you can't practice medicine. It takes a residency to make a practicing, unsupervised, safe physician. So you can go to medical school, but that doesn't get you anywhere except for about a $250,000
Right. And to Dr. Isaacson's point, I would assume that the learning for you and the comfort for your patients, do you find your patients are pretty comfortable with this setting?
Oh, yeah. The patients have been very accepting of it, and that's a shout-out to the patients for their cooperation in helping us increase our learning and our training as a physician. And, it takes a lot to sacrifice your own health for the betterment of the future of medicine. So, and the patients have been extremely open to that, and not only just in the clinics, but also with our other rotations and different other rotations like OBGYN. I just finished my orthopedic rotation at Tri-City Orthopedics, and all the patients have been fabulous.
And Dr. Shah, the same to you. Are you finding, wait a minute, you got 20 seconds. We're going to see how your skills are in a quick answer here.
Are happy. No.
You're all But you have that, when you go out and have your little conference, is that a quick conference? It must be, I guess, because you want to get back in and share the news with the patient, right?
Yeah, because we have about 10 to 15 minutes to talk to them, and then we come out and talk to the preceptor.
Awesome. Fascinating information. More of our program in just a moment. Stay with us.
You're listening to Kadlec on Call on 610 KONA. This program provides general information only. Any comments or information presented are strictly for educational purposes. Kadlec and 610 KONA do not endorse any of the suggestions made by the presenter or callers. Now back to Kadlec on Call. Once again, Jim Hall.
And welcome back to Kadlec on Call. We're talking about becoming a physician, and especially a family practice physician, talking about Kadlec Regional Medical Center's family medicine residency program that started this past July here in the Tri-Cities. The first 6 physicians in training are in the midst of getting their education over in Richland, and it's been a fascinating visit with three of them. And I should give a mention of the other three residents, and actually I think they have been on our radio program when we first discovered them last spring. But Daniel Torba is one of the MD residents. Zubair Rahman is one of the physicians, and the third is Patrick Johansson. And Patrick, I understand, isn't he? I think his wife's family is from the Tri-Cities, if memory serves correct. Is that Amy is nodding her head? Amy Carrasco, our Director of Graduate Medical Education. So we touched on the first half hour that there is a physician shortage, and especially in the family residency, family practice arena. And I want to, Dr. Eric Isaacson is the program director, and before we let him go, I wanted to ask him about that. Is I know it's particularly acute in the rural parts of the state. Is that just because obviously there's less people that live in these rural areas, so not as much of a supply of physicians? So is that where the shortage is really acute?
Yeah, that, and it's also how we support as a medical community and medical care system, support physicians in rural communities. And there's a big emphasis now because of that shortage to train residents closer to where the need is. It's estimated that about 60 to 70% of graduates of a program will locate within 50 to 75 miles of their place of training. And then they've got a network of colleagues and consultants that they know who to go to for help. And also there's an opportunity that I've learned in my program director development to support those physicians out in those communities more completely with electronic health records and easy access to consultants and a shared call system so that these practitioners in rural communities aren't on call every night or having patients show up on their doorstep at 2 a.m. with a question. So there's a way to do that better, and we think we'll be able to implement that here with our training program at Kadlec.
And I know certainly Kadlec's market area, that it's service area, the Tri-Cities obviously about 250,000, but geographically that population extends out into southeast Washington and northern Oregon, and I've heard the catchment areas as high as 500,000 people if you really think about it. And so, and a lot of those areas are in these rural areas that have smaller hospitals or maybe not even have full-service hospitals that have relationships that transfer patients into Kadlec, correct?
Yeah, that's really true. There's a number of critical access hospitals where family physicians oftentimes are the primary doc taking care of and stabilizing patients with common medical problems but needing to be ready to transfer to a different level of care with consulting services available.
We have three of the residents here with us live in the studio. Dr. Tyler Clark. Tyler, I want to ask you a quick question regarding what Dr. Isaacson has said. Is that part of, I'm not going to try and put you on the spot, but he mentioned that a lot of the residents, when they finish, they end up staying fairly close. But I mean, is that kind of the idea? You're whether you do or not remains to be seen. But obviously, you grew up in this part of the world, and so you may see this rural component that he's talking about of why there is so much more need out in these rural parts of the country.
Yeah, that was one of the real draws coming to this program. But I think most of the residents will agree that it's going to be hard for us to leave once we finish.
Now, does any of your training, and I'll bring in Dr. Tahir and Dr. Shaw too to this question. Does any of your training include going out into some of these rural parts of the area that Dr. Isaacson was describing?
Yeah, it does. So even though we're located in Richland, we've gone as far as Pasco so far, and it's only been 3 months. And rural training is part of our 3-year course. So we'll be doing that as well.
Dr. Shaw, does that have an interest in your area of expertise as well? You might end up in a small community, or you may not.
Well, like Tyler said, it will definitely be difficult for me to leave, and I don't want to leave, and certainly that is part of my plan.
And I'm not trying to put you on the spot.
But no, I agree, and I just finished general surgery rotation, and just part of that rotation that I saw a lot of patients just from a surgical perspective. We had a patient that came all the way from Bickleton, Washington, which I had never heard of.
The Bickleton Pirates. That's one you can lay on the next time.
Yeah, the Pirates. And apparently I learned it was a town of 88 people, just a population
Bluebirds
of 88
are big in Bickleton.
And yeah, I have never been there, but I believe you. But it's cool. Things like that, areas like that actually need medical attention, and sometimes they have to travel for 2 hours, 3 hours, and especially for a surgical patient, that may be a decision very hard to make, whether they want to seek help or not seek help for being able to transport to go back home. The recovery times, everything takes into account. So if we're able to access these areas and provide that kind of medical care, and that is the whole idea of moving forward.
You mentioned, and Dr. Tahir mentioned he did an orthopedic rotation, and you mentioned that you just did a surgical rotation. What are those like? Those are surgery pieces. So when you're in that rotation, are you actually in during the cases?
Oh, absolutely. So the rotation I finished with orthopedics, it was excellent because I would see those patients in clinic with the doctor, and then again I would see them when they're actually having the surgery, and I would be assisting the surgeon who would be performing the surgery. So it was a full scope of the whole practice, and that's going to be essential because, as you know, family medicine, there's no patient that we don't see. So it'll be excellent when it comes to different patients with different problems, and we will be able to address them, or at least be able to give them some sort of insight into each problem.
And Tyler, what did you said so far, the rotations you've done?
So I started with hospital medicine.
And so basically, for people that may not know, there's hospital-based physicians, right, that manage the care of the patients in the hospital. So you're working with those doctors?
With the hospitalists, yes, to best manage the treatment for the patients in the hospital and then get them back to their families.
Interesting. And again, are you meeting people, I imagine, from all over the region?
From all over the region, all over the country.
Dr. Isaacson, I know you have to leave us in just a moment. I have one more question for you, and I wanted you to touch on, these guys have mentioned that the preceptors, your colleagues in the medical profession that help train these physicians, but there's also community physicians that are also pitching in well. I just want to give you the opportunity. I know there's a lot of people that are helping make this happen, aren't there?
Yeah, well, even before we started, we had to create a list of community physicians who would be willing to teach. And now that the residents are here, we're trying to make them good on their promise. And so the training program is really a labor of love for these community physicians who are choosing to participate. They're teaching their future physicians. They're teaching their future colleagues. This is sort of the way we make doctors for the future. There's not any monetary gain for that. In fact, sometimes it can impact their productivity in their clinic because you have to take time to explain what you're doing and demonstrate some technique to the resident in training. So these community physicians who've chosen to be participants are greatly desired, and we're very grateful for their participation.
I lied. I have one more question.
Oh, good. Go ahead.
I did have to ask you, obviously, the education that you're providing these gentlemen in the program. I'm guessing you're learning a little bit yourself?
Oh, and that's the other thing. Yeah, part of the benefit of being involved, whether you're a community physician or faculty member, is we get to stay on the top of our game as well. So we get to teach, but we also get to be questioned by our learners. And our learners will push us on the cutting edge of what's new and different and all that. So, yeah, a big benefit and a big draw for a lot of the folks who've chosen to become faculty is to keep us on the top of our game, to keep us at the edge of medical knowledge, and it's very, very satisfying.
That's Dr. Eric Isaacson, who's the program director of Kadlec's Family Medicine Residency program here in the Tri-Cities, just getting underway over in Richland. And Amy Carrasco, they're just in the process of recruiting the next 6. And I know that process takes place now, but ultimately next spring you'll be bringing the next 6 in, and they'll start next July. But we have to take our final break. Thanks for joining us, Dr. Isaacson. I know you have to run. We have one more segment with our guests remaining. You're listening to Kadlec on Call. Back with our remaining minutes in just a minute.
You're listening to Kadlec on Call on 610 KONA. This program is not a substitute for direct consultation with your own healthcare provider. Always consult your healthcare provider for your specific condition, especially if you have or suspect you may have a medical problem. Now back to Kadlec on Call. Here again, Jim Hall.
And just a few minutes left with our residents here as part of Kadlec's Family Medicine Residency program. The first group started seeing patients back in July, and we have just a couple of minutes with each of them to share some more insight. And before we let you go, let's start with you, Dr. Tahir. You started seeing patients in July, and I know obviously 4 years of medical school, it's grueling, and you learn all kinds of things. But now it's the next phase has begun. Is it really that feeling of satisfaction, scared, all of that stuff rolled into one when you started in July?
Oh yeah, definitely. It's a sushi of emotions. You're nervous. You don't know. I guess the first thing I would say is being in the first year of residency, you get to have confidence in what you know, which is very little, and what you don't know, and know when to ask for help and when to seek the advice of your other physicians that are, guiding you and supervising you. But yeah, it's been a wonderful experience having that responsibility for patients, making judgments on what treatments are better for your patients. So it's been amazing in that aspect of it, but it's also been a little nerve-wracking, having that responsibility again of somebody else's life in your hands. But so far, it's been overall an amazing experience.
And you just see, people call and I want to make an appointment with Dr. Tahir, and that's the way they do it, right? That's just the way it works.
Yeah. So we have our profiles online. Go check it out on the Kadlec website. And patients.
This guy should have his own radio show, I think.
Yeah,
that's cool.
Yeah. So So patients can, just call the Kadlec Residency Clinic and request a physician, and there's someone to get an appointment.
Well, Dr. Tyler Clark, the same questions for you. Is it something that's what you thought it would be when you started your residency, or you're just thinking, okay, I'm on my next journey as part of getting this finished?
It's been precisely like Dr. Tahir said. We've had some really great, genuine life experiences that I'll always remember.
And is it kind of sobering where you realize, you sit there and go, wow, this is really neat what I'm getting to do?
It is, and we have great support, so we always have people behind us.
What's the next best thing you're looking forward to doing that you haven't gotten to do yet, I guess, from these rotations in your schedule?
Well, every day is a surprise, so tomorrow I have a lot to look forward to.
Oh, that's awesome. Well, thanks for joining us tonight. I know you guys are busy, and thanks for making the time over here and trying to figure out how to get to this radio station at the corner of 28th and Lewis. Getting to 28th and Lewis is easy. It's getting to the station that's a challenge. But finally, Dr. Shaw, the same questions that I've had to your colleagues here. Has it been what you've thought, and is it just kind of the next step in the process, or has it been this is very rewarding, and I love this stuff?
Well, just like you said, it's been really rewarding, very, very excited about this opportunity, a lot more than what I expected. And certainly it's a transition from being a student to being a resident, because you not only have added responsibility on you're personally trying to develop that confidence in treating the patients yourself, but at the same time, when you graduate medical school, you have that MD after your name. I'm done, I'm a doctor. But when you really start seeing patients, you realize that there's still a lot more practical learning, developing relationships with patients, and all that, I guess, is a cumulative effect that we have to be patient in learning about.
What's been the hardest part? Is it the medical learning, or has it been the patient relations and just making sure that you're making that patient feel comfortable when they're with you?
A lot of the times it's a mixture of the two. Like Dr. Isaacson had mentioned earlier, he's got a following of patients for the past 33 years. There are patients that are very comfortable in his care, and for them to step out of that comfort and have a new young physician look at them and come up with diagnosis and try to help them while Dr. Isaacson's been following them for all these years. We have to be very careful about how we approach them. And developing those relationships has somewhat been rewarding and at the same time difficult to approach. You have to be you have to have the patient's comfort in mind. So
awesome. Well, I want to finish with Amy Carrasco, who's Kadlec's Director of Graduate Medical Education. And Amy, from when you started this journey several years ago and to where you are tonight, and you sit and listen to these gentlemen talk about their experiences, the community's in pretty good hands with this program, it seems like.
The community is in very good hands with a program, with the residents that we have now, with our faculty and our supporting community physicians. The training is just very high quality. They're getting great experiences, and the patients have, just come to us. In fact, it's sometimes a challenge to get in. We didn't know if patients would follow Dr. Isaacson, Dr. Carlson, and Dr. Gaba, but they are, and it's been great because it's been great experience and a lot of teaching going on there. And I will say, as far as to watch the program grow, I'll just quote Tayab and say it is a sushi of emotions, that new terminology I've learned tonight, but all rolled into one. To see them grow, I'm very proud of who we have. I feel blessed that we have this group of physicians physicians here to take care of our community members.
And one last question. You'd mentioned that you're in the midst of the year-long process to get the next group of 6. So there will be 6 coming in next July and then a third 6. So when it's fully operational, there will be 18 physicians in training at any one part of their 3-year training?
That's correct. Each class will kind of oversee and mentor the other class. So this is actually the most taxing year for physicians and faculty because we're learning and growing along the way. But when this group is in their 3rd year, they will be the chief residents. They'll be helping to guide and give direction. So we're laying some great foundation with the care and education they're getting right now.
So, gentlemen, remember what it feels like 2 years from now when that last group is sitting in your shoes. I want to thank all of you for taking the time. You're wonderful men, and we're lucky to have you in the Tri-Cities, and we wish you all the best, and we wish you all the best in your patient care during your time in the residency program. Amy, thanks for joining us, and Dr. Isaacson, if you're driving down the road, thank you for joining us as well. We appreciate your time and all that you do to benefit healthcare in the community. And that's it for this edition of Kadlec on Call. Have a wonderful week, and we'll see you right back here again next Wednesday evening. Good night.